All right. Looks like the majority of the attendees have already joined, so I will go ahead and get us kicked off. First of all, thank you all for joining. Welcome to our discussion today on how MTM's Mobile Integrated Health Program can help close care gaps and provide critical support to mothers and infants. As you can see, we are recording these sessions, and if you do have any questions as we're going through, please just enter into the chat. We do expect to have time available at the end to go through questions, but even in the event that we don't, we'll certainly reach out to you afterwards to follow up and discuss in more depth. So with no further ado, I will first introduce your presenter team today. I'm Kelly Turpin, MTM Health's National Mobile Integrated Health Director. Just a little about me. I have spent my career developing and implementing clinical home-based care programs, working with EMS, CMS, and health plans, and have really spent the last decade pioneering industry-first mobile health solutions across the globe. My passion is breaking down access barriers and closing care gaps for the vulnerable populations. Colleen Schley has extensive experience in the healthcare industry, working with large healthcare systems and managed care organizations. Since joining MTM Health in 2019, she's played a key role in enhancing provider relations and implementing innovative solutions in markets nationwide. As a licensed Florida paramedic with over 20 years of first responder experience, Colleen brings a lot of valuable insight into our mobile integrated health program. Tracy Kalmar also brings decades of experience in emergency medical services to her role as a former paramedic and current operations leader. She has firsthand insight into the critical role of mobile integrated health and improving patient outcomes. Her expertise in innovative healthcare solutions allows her to develop strategic partnerships that enhance care coordination and access for vulnerable populations nationwide. And Kyra Betts is a passionate maternal and child health advocate, policy strategist, and community educator. As a manager of policy and advocacy at Generate Health, Kyra works to address systematic disparities and uplift Black families. She's a creator of the Dad's Doulas program in partnership with Dear Fathers, which equips Black fathers with the tools to advocate for maternal and infant health. With a background in community engagement, legislative actions, and birth equity, Kyra is committed to ensuring every family thrives. So now that you know your team of presenters today, let's kick off the discussion. Kyra will start with providing an update on the current state of maternal and infant health in the U.S.
Wonderful. Welcome, everyone. I'm so happy to be here with you all and to be able to discuss the current status of maternal and infant health in our country. It is unfortunate that this is the status, but I'm very happy to be here. So I want you all to just take a moment to look at this map. While it may look like a Verizon or an AT&T map, it is not. It is a visual depiction of the state of maternal care in the United States. Of the 3,142 counties in the U.S., 1,104, so quite a bit, counties are classified as maternity care deserts, meaning there are no birth centers, no hospitals, and no obstetrical clinicians, leaving 2.3 million reproductive age women without critical reproductive and pregnancy care. Though nearly 98% of all U.S. births happen in a hospital, 52% of the counties do not have a hospital with an obstetrical unit. So there may be a hospital, but they have no ability to care for vulnerable pregnancies. That's 1,610 counties with nothing, like absolutely nothing, and another 1,017 with just one hospital or one birth center. And that is not enough. Those are typically very small units, and those are not enough. And this problem that we all live with is not without immediate and pervasive impacts. When you think about the lack of access, of course, things are happening, right? Of course, we have inadequate access to emergency maternal care, inadequate access to consistent preconception and prenatal care. We know that prenatal care can decrease infant mortality, and we'll talk more about that in a second, and inadequate access to physical and emotional postpartum care. And that lack of access has direct impacts on the lives of maternal and infant individuals. So anyone who's having a baby, anyone who's thinking about having a baby, and those babies have critical issues. 60% higher maternal mortality in rural areas. 60%. That's not 5% more, that's not 10%, over half, right? 53% of maternal deaths occur after delivery. So in the previous slide, I was talking about access to emergency maternal care. And sometimes people are looking at seconds and minutes and not the hour or 2 hours or 3 hours they may have to travel to get to care. You have 50% or more of pregnancy related deaths did not receive timely or adequate care. Makes sense, right? If they're not getting to care in time, obviously we're going to have the most um, mortality in those areas. And 60% of maternal deaths are deemed preventable. That means 60% of these individuals, had they received adequate prenatal, pregnancy, birth, or postpartum care, would still be with us. And it doesn't just stop at the moms. The babies are also suffering. We have over 130,000 babies being born without adequate care, and 18,000 of them received no pregnancy care at all. That means they didn't go to one single appointment and often did not arrive into an obstetrical unit until the baby was being born. Over 51,000 preterm babies were born to people living in maternity care deserts between 2020 and 2022. And 65,000 preterm babies to people living in low and moderate access counties. I know when we think about how many babies are born a year, like, oh, that's not that many. The number should be zero. We should be having zero babies being born without access to appropriate, adequate, culturally sensitive prenatal care. Inadequate care could prevent up to 60% of the preterm related deaths. So, in the same way that those maternal deaths could have been prevented, these infant deaths can be prevented as well. And so we leave these families falling without a net. We all know that safety net sources and resources are lifesavers. When I had my child, both of my children, a social worker came to see me in the hospital. A representative from Medicaid came to see me in the hospital. Lactation came to see me in the hospital. I did not have to go outside of my home or outside of my immediate circle to find those resources. They were provided to me. But what about those over 1,000 counties that don't even have the hospital access? Who is serving those mothers? Who is helping those mothers? And who is supporting those mothers? We know that safety net programs are essential supports designed to help individuals and families meet their basic needs, particularly those in vulnerable or underserved communities. And we have to remember that these people are not vulnerable because of some moral failing, some economic failing that they could control. They are under resourced and they are underserved. And then, of course, we have the social determinants of health, and some people like to call them the political determinants of health. But what we know is that the presence of healthy food, education, healthcare, economic stability, and safety in the place where we live have a direct impact on our ability to be healthy and to thrive. Without safety net services, without having our social determinants of health met, families do not have the resources that they need to thrive. This is a photo that I feel like depicts a very happy, healthy family thriving. They have food to eat, they have a place to live, they have shelter, they have water, they have all of the things that they need, and they have their community, their unit, their family unit is intact because they are having their needs met. But for too many Americans, they do not have those needs met. Thank you. And here are some of my resources. I'm sure they'll be sending that out so you guys can check out some of the things that are out there because it really is the problem that we all live with and we're all responsible for.
Oh, thank you, Kyra. Thank you for that overview and honestly for the amazing work you and your team are doing over at Generate Health. It's impactful. So we know that there's room for improvement in the quality and availability of care, specifically for mothers and infants. In fact, CMS in their recent press release advised that despite spending more per capita on maternal health care than any other nation, the US has disproportionately high rates of adverse pregnancy outcomes compared to other high income nations. And I don't think, that that's a surprise or new information for anybody on this call. But again, it's an important topic. So I'll now turn over to Tracy to talk about, what can we do to solve these issues?
Thank you, Kelly. Thank you, Kyra. Well, what can we do to solve? That is the question. And one of the solutions that MTM has come up with is our mobile integrated health. Our mobile integrated health program impacts the safety net services, which Kyra just discussed. One of the first mobile integrated health programs, was introduced to address underserved rural communities, where, according to the National Institutes of Health, have 14% of our primary care physicians serving 25% of our population. Mobile integrated health is a patient-centered care delivery model that brings care to the patient by coordinating resources among local EMS, local healthcare providers, community-based organization, virtual care platforms, and the health plan. We aim to improve health outcomes, patient experience, the integration of care. We work to decrease the overutilization of emergency medical services, reducing hospital readmissions, and increasing access to provide a more proactive preventative care to our patients. Our MIH programs are designed to increase availability and access to care by navigating patients to the right care at the right place at the right time. This saves community resources, it helps manage the cost of care, and it improves the patient experience. On the next slide, you're going to see how delivering care where it's most needed helps patients. We partner with our health plans across the nation to implement local, national, and state-driven strategies to deliver care directly to the patients in their homes and communities. Our community health workers provide vital services, including prenatal screenings, postpartum care, social needs interventions, improving access and outcomes for both mothers and babies. Our community health workers promote care that is person-specific, culturally sensitive, and rooted in active listening. Our community health workers work on developing a trusting relationship with these mothers, with the goal of making the mothers more empowered to manage their birth experience. The benefit of greater access to these resources includes reduction in C-sections for low-risk pregnancies, shortened labor time, lower utilization of pain management and lower utilization of pain medication during birth, and lower rates of postpartum anxiety and depression. As we move to the next slide, you're going to see that our approach is a whole person approach to maternal and infant health. We utilize the development of this whole person approach to pregnancy, childbirth, and postpartum care that addresses not only the physical needs and the mental health of our mothers, but also the social needs experienced during pregnancy, addressing those social determinants of health, or as Kyra stated, the political determinants of health, with the ultimate goal to reduce disparities in access and treatment. The model aims to improve outcomes and experiences for mothers and their newborns. On the next slide, you'll see that we have these key aspects that we integrate into our mobile integrated health program, allowing greater access to these resources. We work with community resources and provide education that's able to promote care, again, that's rooted in active listening. Our protocols are shown to improve health outcomes across multiple clinical areas, but including hypertension during pregnancy, cardiac conditions, and then care for pregnant and postpartum people living with substance use disorders. Moving on. We use a two-tier system. The first tier is our community health workers, and our community health workers they're non-clinical, and they work with members in their home to address health education, education of their managed care organization's benefits. So what services are available through our managed care organization partner, and how does the mom navigate those services? How are they educated on those services, and how do they get access to those services? That benefit navigation is key to ensuring that the patients understand that the managed care organization cares about them and is providing these services to assist them in attaining their best health. The second tier is our community paramedicine, our community paramedics, and they do the clinical care. They can do EKGs and other lab work, blood work, but they can do it in the home where the patient is. So again, the right service to the member at the right time in the right place. On the next slide, we're going to talk about the transitioning maternal health that CMS, it's their CMS's newest model, and they're going to be implementing that in 2026. So our mobile integrated health program supports this model. It aligns to the work we're already doing in the space. We have extensive experience working with CMS to implement and provide required documentation. As we all know, when working with those CMS programs, the documentation is intense and they want documented outcomes. MTM has experience in this area regarding innovative care models, and this will be a game changer for our moms. There were 15 states that were selected for funding for the transitional maternal health pilot, and we are happy to do to assist any of the Medicare organizations in those states with their maternal transitional maternal health pilot. As part of a follow-up discussion, we can share very specific data and outcomes with you on the scope of that work and the scope of the work we did in 2024. That being said, I am going to turn it back over to Kelly. Thank you, Kelly.
Oh, thank you, Tracy. It is exciting to see that CMMI is, providing support and visibility on such an important topic, this year. As a follow-up to your overview on how community health workers and paramedics can work with members to close these care gaps, I will. I'd like to spend a little time reviewing some of our most recent outcomes for the Medicaid members that we've been, working with over the past years. So first, I just, want to reiterate some of the information we've spoken about. We do take a whole person approach to pregnancy, childbirth, and postpartum care, addressing, the physical, the mental, the social needs that are experienced during pregnancy. But what does that actually look like? To begin with, our fully trained and certified community health workers provide services such as the screening and assessment. They're also very adept at locating hard to reach members because these community health workers live in these communities they serve. They're very familiar, with the communities, with the services available, with the area. And as such, we've seen really great, response rates from locating members that, otherwise were challenging to track down. They provide home visits. Along with that home visit, is services such as remote patient monitoring, preventative care, scheduling, and transportation needs. As we know, they all go very much hand in hand, and that's, the SDOH that, has been spoken about previously, health education, and along with that is, social services referrals and care coordination. It's mobile integrated health. The integrated part of it is that we integrate, the full care team and work with primary care, case management, specialists, EMS if they're calling 911, or for referrals from high utilizers or members who they identify are, in need additional services. So those are some of, the actual things that we have done with the community health workers. But for the clinical side, community paramedicine, we leverage our network of EMS providers to support maternal and infant health by providing the accessible in-home healthcare checks and education between their regular doctor's visits. And this is especially important, right, in areas that Kyra referenced, where services might not be readily available or the wait times might be very long. We can, import those services or supplement them by using these community paramedics to come in and help the members in their home. The community paramedics do play a vital role in the healthcare deserts and can help close these gaps. Again, where services may be lacking, or even in communities where there is adequate services, the wait times can still be, very long. And also, we all know that there can be thousands of reasons why a member can't make it in to see their OB doctor or their primary care doctor or their pediatrician. But you know what? If we bring the care to them, it could be a different scenario. We meet them where they are because, again, the goal here is to close the care gaps and not just keep doing, duplicating services that are already available. But some of the key ways that community paramedics help with maternal and infant health, the reality is completing these prenatal care checks, conducting regular home visits to monitor vital signs, assess fetal well-being, and address concerns between the appointments. Providing also the postpartum support, checking on the new mothers, monitoring the infant growth and development, providing clinical advice and support after delivery. And all this information, just as an aside, it's all data points that can be shared, back with the case management, back with the primary care physician, back with, again, the whole integrated care team. So care is never provided in a silo. But also identifying risk factors and potential issues like gestational diabetes or postpartum depression, again, through these regular assessments. And then also working to bring in the local community health workers who can then refer the mothers for the needed community services, whether that might be food assistance, mental health support, transportation needs. So it very much is a integrated team working, again, for the whole health of that member. Providing early intervention and promptly responding to potential complications during pregnancy or postpartum, facilitating that timely access to medical care. Again, they can develop these relationships, building trust, establishing that trusting relationship with the mothers that occurs from meeting them where they are, regular home visits, a comfortable environment, which, in a lot of scenarios can allow for more open communication to not only discuss, raise, but also provide solutions for their concerns. So the benefits for community paramedicine for maternal and infant health, the early detection and management of potential issues that leading to, better health for mothers and babies, that leads to improved health outcomes, increasing access to healthcare for underserved populations, potentially narrowing health gaps, that leads to reduced disparities and preventing unnecessary emergency room visits by addressing these concerns early on, that can lead to more cost-effective care. But next, I'd like to speak to you a bit about leveraging our services to address HEDIS gap closure. These 4 measures listed are ones that we'll talk about and all, can be addressed through our mobile integrated health program. The first, timeliness of prenatal and postpartum care. I don't think that I have to define these measures for anybody. Anybody on this call will be well aware of them. However, and just for clarity, this measure is defined as a percentage of deliveries that received a prenatal care visit in the first trimester and the percentage of deliveries that had a postpartum visit 7 to 84 days after delivery. So our program is designed around providing these very specific tailored services, such as, what we have outlined here on this slide. Again, we can't stress enough how building that trust and that relationship with the members generally in their home, really leads to improved outcomes. And, again, the monitoring, recovery, early detection of complications, these are things that just really are difficult to replicate in another scenario and provide so much value. So to share some outcomes for this one in a 2-month period that I monitored, MTM's community health workers assisted over 200 members to complete their pregnancy screeners, which, as you know, provided us that critical information on the services that we could provide to support them. And of course, this information is critical back to the health plan as well, specifically because not all these members, were able to be reached. So we share that information and it helps to guide the care plan specifically for that member. We've also focused on postpartum visits and, in 1 month, MTM CHWs helped over 350 mothers to complete a postpartum visit. But, our services are not just a phone call reminder. We meet the members where they are and help them locate a provider if they don't have one, assist in scheduling if they need it, assist with transportation if they need it. We provide a follow-up after the appointment to first ensure that they actually were able to make it to the appointment, because I can tell you firsthand, we get a very high response rate of saying that they couldn't make it for a reason. So you know what, that follow-up is so critical because we say, all right, let's get you back on track. Let's get you rescheduled. But also to see if their questions were answered and if we can assist them with other needed services. Same thing. I can't tell you how often they'll go to that visit, but they still have, I need to see this. I need help where do I find this specialist, or I have to go back in, 2 weeks, or, so they're generally, it's not a one and done. And getting them into those postpartum visit, as everyone on this call knows, it's not a one and done. So the social needs screening and intervention, this measure is the percentage of members who were screened using the pre-specified instruments at least once during the measurement period. And this is for unmet food, housing, transportation needs, but also that they receive the corresponding intervention if they screen positive. And generally speaking, exceptionally high number screen positive. So they they need that follow-up assistance to address their social needs. Our mobile integrated health program provides both the screening and the intervention. In some data I pulled in the first 7 months of one program, we completed nearly 900 health risk screeners and had a 70% member contact rate. I think it's worth noting that these members, the 70% rate refers to what have been designated as UTC, unable to contact members. So these were the members that had been unresponsive to the health plan's attempt at phone outreach historically. So we just had a really good success leveraging community health workers within the community, to track them, not to track them down, but to locate them and talk with them. Our extensive network of community-based organizations and the added benefit of the local first responders on our team, we really can ensure that the member receives housing and food assistance as needed. And transportation, well, that's our bread and butter. So we definitely have the networks in place to close transportation gaps as well. Well, child visits in the first 30 months. So this measure is defined as the percentage of members who had both the 6 or more well child visits in the first 15 months, and then 2 or more well child visits in the following 15 to 30 months. So relating to this measure, I pulled some data on our community health workers. They completed over 370 encounters with 220 unique children, in which we not only assisted them with completing their well child visits, but provided that end-to-end care that we talked about, starting with the screening and needs intervention through to scheduling, resolving, the social determinants of health, the SDOH needs, and again, just ensuring that these critical well child visits actually were completed successfully, and that there's, not follow-up or additional questions or additional specialists that are needed. So now that you've heard a bit about mobile integrated health and the outcomes we've achieved, while working with Medicaid members in a similar capacity, we'll kind of finish with what's in it for you. I'll turn it over to Colleen to speak to you more on the ROI, the return on investment, and the value, that you can see by partnering with MTM Health.
Thanks, Kelly. So most of you know MTM is your trusted NEMT partner. Because we already have a national presence of network for providing transportation, we have established relationships with a national network of EMS partners to help close the gap for integrating mobile health into most of these programs. We also have the ability to supplement with the community health worker program to fill in the gaps in between that lower level of acuity and what is needed at a paramedicine level. We have relationships on a national level with national stakeholders such as the National Fire Chiefs Association, local and state departments of Health and Human Services, the CHW, the Community Health Worker Associations, and EMS authorities. We have an extensive experience with standing up MIH programs, even in some very short time frames. We've assisted some of our partners with getting some programs up and running from ground zero through to a successful model. Proven data outcomes, as Kelly shared there, we're collecting really relevant data that has been very, very exciting for our partners as they move through these programs with us. We have a unique two-tiered model. So we have our CHW network that addresses the non-clinical aspects, and then we do have the community paramedicine to do the more extensive clinical-based products that might be required for some of these patients in these demographics. We have experience integrating quality metrics and goals, such as your HEDIS measures, or any other measures that are important to our partners as they move to expand their access to healthcare, and can be included in the mobile integrated program delivery. We have a best-in-class technology platform that offers seamless integration with case management with our partners, EMS and local government platforms as well. We have a focus on reporting and analytics. We know that's important to a lot of our partners to provide seamless data transparency, real-time trending, access to reporting, cost of care metrics, as well as NPS surveys, automated or ad hoc reporting that may be important to our partners, custom dashboards that can be built to model the needs of your case management or of your plan priorities. and for detailing member outcomes. Programs are designed to connect the member care team, including your case managers, emergency responders, clinical practitioners, and community services through our extensive network of community resources. We can immediately partner to address any emerging social determinants of health as well. So the state of things, as you know, Ms. Betts was talking about. So this right now, currently, if a 911 call comes in for EMS, 70% of those result in a transport to an emergency department. 50% of those, these are all, you know, close estimates, 50% of 911 are for actual emergent care. 20% of those calls are non-emergent conditions. So those are folks that end up in the ER for something that could have been addressed at a much lower level of entry, such as a PCP, a health department, and urgent care. But they end up in the ED at a much higher cost of care, far more invasive time for them. 30%, however, result in a patient being left at home to navigate services on their own. And as Ms. Betts alluded to, a lot of folks, you know, trying to navigate out in some of these deserts, they're just really, truly left on their own with not any resources to really tap into. So this is how that it can be a real challenge for our pregnant people to get the resources that they need. How mobile integrated comes into this is the 911 call may still come in. The emergency transport for those that are emergent critical that need ER care, they'll still happen. However, there can also be a referral to MTM for mobile integrated. So for those additional services, that include the community care providers, health education, benefit navigation, all of the services that our CHWs and paramedicine can provide to these folks at a much lower level of acuity than an ER. So if you look at that 20% of folks that maybe didn't need to end up in an ER, and that 30% that are left without transport, you're talking about 50% of your population that would end up with services that are more appropriate or timely and more closely designed for their actual needs. Kelly, I'm going to turn it back to you.
Thank you. Yeah, that's great, Colleen. And, you know, thanks for sharing that information, especially, you know, I think all of us in our time with EMS know that there is a huge opportunity to provide more appropriate care to some members when they call 911. And we certainly know that a large percentage of those calls are not, you know, true medical emergencies. So I think, you know, anything that we can do to, again, provide the right care, the appropriate level of care, as opposed to just, you know, transporting to the emergency room because that's the only available option. I think, you know, we have that opportunity to do better. So I really thank you for calling that out. Those of us who come from EMS also know that the 50% could also be a conservative estimate because I've been in operations where, you know, the crew sometimes will report as high as 90%. Again, it's all informal and it's anecdotal, but I think what we all can agree on is that there's opportunity there. Okay, so I personally would love to continue the discussion. I've put my contact information up on the screen, but you can also please reach out to any of our presenters at any time to speak more in depth on, you know, the specific needs or the specific situations for your members. Since it appears we still have a little bit of time left, I would like to, you know, open it up if there were any questions in the chat for any of us.
There are some questions in the chat, Kelly. Some great questions.
All right.
So would you like me to lob those at you?
You can lob them at the panel. Yes.
All right. From Cindy, she was asking about how we determine if a member's information is going to a specific doctor for a specific reason. How do we gather those statistics? I'm assuming this is around the surrounding when we're doing our information gather, our CHWs are doing our information gathering. If they get information that's needed to be shared with a specific doctor.
Yeah, so, as part of the workflows, if I'm understanding the question correctly, but, as part of the workflows, we talked about, working with that integrated care team and being, kind of the connectors within the community and with across their care teams. So generally speaking, either on intake or on the health risk assessment, it goes through all questions such as, do you have, in this example, a current primary care physician. But even if, say they answer no, we're working closely with them. So maybe if they don't currently have one, we help them to get a primary care physician. So, all of that is documented. That's important information. A lot of our health plan clients have wanted that as well. So it's information we keep in the chart and that we also share. So that's how we know if they're working, who their primary care physician is. But as far as what information, is critical to share, again, this is part of the discussion, the whole care for the member. Some things we just, we get them into their appointments, make sure they're having those discussions, coach them on, if needed, important things to talk to, say, their specialists about. So it really is just kind of part of, the interactions with the members all around. And as we all know, every single scenario is unique, isn't it?
I think I got a thumbs up regarding your response on that one. The next one that we have is from the 200 members that we were able to make outreach to, what was the original targeted number that we attempted to reach? So what was our success rate, basically?
So this is for, off the top of my head, I don't recall a specific number, a specific goal as much as these are the members and just work through them with the time that you have. So I want to say it was, yeah, honestly, I'd have to follow up on that specific stat.
All right, I will, Cindy will get you that information after the presentation. There was another question from Crystal that if you are doing a prenatal check, would services be billed as a prenatal visit? And I think that's going to be state specific, right, for the CHW or the paramedic, but I'll defer to you,
That's right,
Kelly.
Teresa. No, you're exactly right. It's slightly nuanced, and I think this would be a great follow-up discussion for us to have, depending, on the state. But I will say there are some scenarios where, we absolutely can bill, or it's Medicaid cover services, and there are some states that aren't there yet. So I think this would be a good one to discuss, very specifics. I will say though, Tracy, just as an aside though, we are also, kind of part of these groups lobbying, with the National CHW Association and working with national, the mobile integrated health organizations to kind of, work on funding models to push this through, state by state through legislation. Because again, we're really involved in, the lobbying efforts on these are important services and they really should be covered if they're not already.
Kelly, can you tell me how much time we have? So we have some more questions. Do we have time for more?
I think we have time for a couple more. I think we have approximately 5 more minutes.
Okay, great. So the next question is regarding screening. Are we probing questions for human trafficking?
There's questions. No, we're not on the screener that we used in the last specific states, but certainly it would be, I think, a good addition. My understanding, at least of the work we've done in the past, is that these are all, approved by, the state Medicaid agencies have a say in approving it. So I think, those would actually be fabulous questions if they're not already on there for us to suggest to be included.
So
Really
I think,
point.
yeah, to add to that, I think we could work with our MCO partner to develop questions and get them approved by the state agencies to ensure that we're screening as appropriate for human trafficking. I know that is a huge concern, a larger concern in some states than others, but a concern all over the nation. The next question is, does the CW, does our community health worker or CHW and paramedic go out together as a team? Or can you walk through a typical member-patient interaction scenario?
Yes. Do they generally go out together? Again, so we develop different program protocols working with, the health plans, the case management team, the local EMS and their medical directors. So it's very much is, a combined joint effort on the requirements. But as a general statement, they do not go out together because, we're trying to either have the CHW go out first, do the screening, collect information, identify, a care plan and bring that back. And then again, generally speaking, we engage the community paramedics for clinical care when and how that is needed. So as a blanket statement, we don't generally send out the clinician to every single encounter, which is not to say if that was the program design and there was a need for that, we absolutely could. But generally speaking, the value of the two-tier program is that, you can leverage the right resource at the right time, which, also realistically plays a role in controlling costs too. So generally speaking, we engage whatever resource is most appropriate for the services that member needs for that encounter.
Thank you, Kelly.
Yes.
Ashley, Colleen, did I get all the questions, or are we?
I think there was a question farther up that was for Kyra that was asking about the deserts. Some around, is that within a county or miles radius? Just as far as the general idea on your map of how those are measured.
Okay, so the map itself is just identified by counties. When you guys send out the PDF version, they'll be able to look at the key on the map, and that'll kind of tell you like which places have what range of a desert or how close they are to being an absolute desert. And then any of the statistics that I said, those are just across the US.
And Lena, I agree with you. I found it very disheartening as well. I had no idea, even though I worked in rural areas for most of my career. To see that on a national level was very disheartening. I agree with you. But I think that's all the questions I saw, Tracy.
I think that is all I saw also. Does anyone have any questions that we didn't get to? If you could throw them in the chat, and I think we have a couple more minutes. Correct, Kelly?
Tracy, there are if you click on the Q&A tab versus the chat, we do have a couple in there as well that we could address if we want to spend a few more minutes.
All right.
And I have it up if you can't access it too, Tracy, whichever you're more comfortable with.
I have the blue spinny thing.
Okay, I'll pull out a couple of those that we can address really quickly as well. One question asks, what types of clinical services are generally provided by community paramedics, Kelly?
Oh, I think this would be a fabulous question for our paramedic, Colleen.
Hi, thanks. Okay, so it depends a lot on the state and local protocols and the local medical direction, but under the scope of practice of a paramedic would follow the clinical items. So we're talking about things such as EKG, Holter monitors, things like that, getting those kind of tracings on scene, interpretation, transmission to a care provider. Invasive labs such as blood draws, blood cultures. We can do immunizations. So when you're thinking about your populations here, any immunizations that may be necessary that get them up to speed before they deliver. We can do medication adjustment in conjunction with their primary care provider or with local med control. If you're thinking about this particular population and you're thinking, things like hyperemesis or the blood testing for Rh negativity, things like that, a lot of those things can be done in the home, which makes sure that they get done timely. If you can avoid a transport for hyperemesis and treat with rehydration in the home, Zofran administration, things like that as well. So anything that falls at a higher level clinical care item that would be above the practice of a community health worker, but that would still provide definitive clinical care in conjunction with med control and online medical services to help address these actual needs in the home for these members. Does that kind of answer your question?
And Kelly, I have another one here that I think is very interesting, will probably be state dependent, but it asks, how does remote patient modeling apply to and benefit the homeless population or members with unstable living conditions?
Yeah, so I mean, I think that if members are homeless, generally the remote patient monitoring is not a service that's available that the health plans offer to them. I've not yet come across one. I do know, we've done kind of extensive research on street medicine programs and had, looked a little bit in depth on, services available to, address members that have, housing insecurity or homelessness. But I would say that remote patient monitoring probably is not high on that list of the services that would be most valuable to that population. I think, getting them in, addressing the SDOH, getting them into providers, providing them a way to actually, get the kind of proactive or preventative care that they need is generally going to be a top priority for those members.
Thank you, Kelly. And we'll go ahead. Sorry.
No problem. Kelly, isn't it true that that unstable living condition would be something that we could identify in our screening and then be able to work in conjunction with our MCO partner to provide options for a more stable living circumstance?
You're absolutely right. You're absolutely right, Tracy. And actually, in our one of our last programs, we actually, worked with quite a few members that had that, housing insecurity. And you're right, it comes up in the screening or it changes and it comes up throughout the course of the time that you're working with them. Oftentimes they might be stable when you meet them, but then, months later things change. But, some of the most, kind of heartwarming and, to me, exciting stories that, I've heard out of my, community health workers is when they really are, so close with, some of these members that they're the first call the member makes when, I'm getting evicted, I'm losing my house, my boyfriend kicked me out, my children and I have nowhere to go. Like there's so many stories where they're community health workers who they call first. And that's absolutely our bread and butter. And that's exactly what we do. We have so many resources. We found, so many scenarios where, we can get them, into housing or alternative living situations and help them to resolve that really quickly where, these members otherwise, like a lot of them have reported they wouldn't have known who else to call. They don't know how to access these services. So I think you're exactly right, Tracy. We can certainly assist with the root cause of those issues, whether temporary or long term.
And Kelly, I think we have time for maybe one more quick one, and that would be, how quickly could you stand up a new mobile integrated health program if we wanted to kick off a maternal or infant health program?
Oh, very quickly, I'll say that as some of you can see, this team is, we're actually, we're very passionate about, not only this topic, but, helping these members. So I would say, generally, very, very quickly, we'll need to discuss size and scope, but we already have these general protocols in place. Our program it can be plug and play, but also, we can tweak it and make the tweaks that you need. But with already having all of that, we can move as quickly as you want to move, as the health plan wants to move, because we can stand up really quickly.
Awesome. There are a few more in the chat, Kelly. Maybe we can follow up directly with those questions that we didn't get to since we're running short on time here.
Yeah, absolutely. For anybody we didn't get to, Colleen, Tracy, Kyra, myself, will all circle back with you. I'll absolutely send out this presentation so that you have all of our details. And we really hope we have the opportunity, to work with you in the future. Because as you can see, I think together we really can, drive some change here. But thank you, presenters.
Thanks for having us.
Thanks for having me. It was a great time.
All right. Thank you, attendees. Have a great day.
Take care. Bye-bye.